Respected President of the Alumni Association of Government Dental College and Hospital, Hyderabad, respected board members of the association, respected seniors, colleagues, and all the participants, good evening to all, and a warm welcome to the webinar on implant prosthodontics organized by the Alumni Association of the Government Dental College and Hospital, Hyderabad. So this webinar is the first of the series of webinars being organized by the Alumni Association, and now I invite Dr. Chandrasekhar sir, the President of the Alumni Association of GDC Hyderabad, to address the session and present the welcome note. Sir, please.
Good evening. Good evening, all the participants of today's webinar. It's been a wonderful feeling, and we are so happy that today more than 500 delegates have registered for this webinar. And I can say that it is one of the, normally we don't see so many members getting registered. And welcome to the first webinar of the Alumni Association of Government Dental College and Hospital, Hyderabad. And we are planning to have a regular fortnightly regular webinars, and I'm sure all the members can really enrich in with the knowledge from the latest updates from dentistry. And I welcome the senior members. Dr. Ramchandra Reddy sir is already there, and Dr. Bapnaya from New York University, Dr. Mahesh. I can't see so many. There are already 140 participants already, and we are expecting much more. And all the senior faculty, all my colleagues, all my juniors, all my students, welcome to this webinar. And let's participate, and let's take great knowledge from the faculty today. All the people who are there, the panelists, very senior people. I mean, they're going to share their knowledge, and all of us will get great knowledge. And let's start the proceedings, and welcome all of you for this today's webinar. Thank you.
Thank you, sir. That's a short, crisp, and a fond welcome from the President. Now I invite Dr. N. Vivekvardhan Reddy sir, convener of the Scientific Committee of Alumni Association of the Government Dental College and Hospital, Hyderabad, to introduce the resource persons.
Thank you, Ram. Good evening, everyone. It's a pleasure and privilege to introduce keynote speaker and other panelists for today's webinar. I'll start with the keynote speaker, Dr. N. Sudhir. Sudhir has joined Government Dental College and Hospital, Hyderabad in 1994, and he has graduated in 1999 with 5 gold medals awarded by the university, and the Chancellor of AP State, Governor of Andhra Pradesh, has presented those medals to Sudhir. Then he went on to do his master's in maxillofacial prosthodontics and implantology from the most prestigious institution in the country, All India Institute of Medical Sciences, Delhi, in 2003. And he received ICD Merit Award in Prosthetics and Best Overall Achievement Plaque presented by the President, International College of Dentists. He is a fellow, Indian Society of Oral Implantology, and also fellow of International Congress of Oral Implantologists. He is a certified implantologist from University of Hardy-Krov, Czech Republic. He was actively involved as a clinical research officer for a dental implant project funded by Defense Research and Development Organization, DRDO, and also Institute of Nuclear Medicine, Allied Sciences, New Delhi. He published many original research papers and presented at World Congress of Prosthodontics and Federation of Dentare International Conferences. He has several publications to his credit and is an invited guest speaker at several conferences. He is presently the professor and postgraduate guide, Department of Prosthodontics, and also the chief coordinator for Division of Implantology, Kamneni Institute of Dental Sciences, Narkatpalli. So we thought we should have one of our proud alumni members as the first speakers, and Dr. Sudhir fits into the role very well. I also have the privilege of introducing our panelists for today's webinar. Dr. Mahendranath Reddy, the noted implantologist from Hyderabad. Dr. Mahi has passed his BDS from Government Dental College Hospital in 1988. He belongs to 1982 batch. Later, he did masters from Bapuji Dental College, Davangere in 1991 in the specialty of prosthodontics. Everybody knows him. He is a very active practitioner in Hyderabad and known among implantology circles all over India and also in the world. He is all working as faculty at Sri Sai College of Dental Surgery, Vikarabad. Moving on to the second panelist, Dr. Vijay Srinivas, joined BDS in Government Dental College Hospital in 1984. And after finishing his graduation from GDC in 1990, he went on to join MDS in Oral Pathology at College of Dental Surgery, Mangalore, and graduated in 1993. He is a very active practitioner, very well known among implantology circles. He is a postgraduate teacher at St. Joseph Dental College, Eluru. The third panelist, Dr. Vasudha Nelluri, joined BDS Government Dental College Hospital in 1995. After graduating, she secured MDS in prosthodontics at the most prestigious university, Benares Hindu University, and graduated in 2005 in prosthodontics. She worked at various institutions as a faculty member. Presently, she is a faculty in the Department of Prosthodontics at Government Dental College Hospital, Hyderabad. The moderator for today's webinar is Dr. Ram Babu Basani. Ram joined BDS in 1997 at Government Dental College Hospital. After graduating, later he finished his master's in prosthodontics from SVS Institute of Dental Sciences, Mahbub Nagar in 2012, and currently working as associate professor in the same institution. Ram is a great artist. All of you know him. He has displayed his work during our Diamond Jubilee celebrations of Alumni Association a couple of years back. And he will take over as a moderator for this webinar. Thank you for this opportunity. And I thank the President and Executive Committee members of the Alumni Association for allowing me to conduct these webinars. And I thank you all for joining us. Have a wonderful webinar. Thank you. Thank you, Ram.
Thank you, sir. Well, the bios of the speaker and the panelists are so inspiring. I guess they'll make an interesting team for today. So before Sudhir sir starts the keynote presentation, I have a request for the audience. Like we're all used to these kind of webinars from quite some time, and I guess all of you know the etiquette of how to present yourselves. But anyway, I'd like to just remind you that please quiet your mobile phones, please quiet your surroundings, and just be calm and just listen to the lectures. And if you have any queries, you can just drop down the queries in the chat box, or you can raise your hands and we'll address the questions. Sudhir sir, you can start your presentation. You can start sharing your screen.
Good evening. Ram, can you hear me?
Yes, sir.
Yeah. Good evening to the GDCS family, our friendly neighbors, and my dear colleagues who have registered for the webinar today. Before I begin, I'd like to extend my heartfelt thanks to the Alumni Association of GDCH, especially the President, Dr. G. Chandrasekhar sir, the scientific convener, Dr. Vivekvardhan Reddy sir. Thank you for that wonderful introduction. And we have amidst us also renowned panelists for the webinar today, Dr. Mednath Reddy sir and Dr. Vijay Srinivas sir. Between themselves, they are the pioneering implantologists in this part of the world. It's an honor to have you as a panelist today, sir. And my dear friend, Dr. Vasudha. When I had to deal with the topic of implant prosthodontics, it's like, dealing with a textbook or a volume or two and having to concise it to the duration of 40 minutes. It was a Herculean task. So I have tried the best I could. And during the course of the webinar, you might noticed that I have missed a few topics, or there are certain lacunae, which will be addressed during the general discussion at the end of the webinar. With that, I begin. Here goes. It was way back in 1982 at the Toronto conference in Canada when Branemark and his team had announced the world the concept of osseointegration. And they had done that by displaying this dramatic picture. And this kind of kept the audience spellbound because they were astonished at the fact that the entire weight of a dog was suspended from a single osseointegrated dental implant from his jaw. And ever since, the captivation stayed, and implantology was all about achieving this rate of success in osseointegration. So implantology grew to be associated with an implant which would osseointegrate and stay firmly inside bone, such that the classical approach, especially amongst the nascent implantologists today, runs like this. The patient walks in, you take a case history, you clinically examine the patient, and then you subject him to radio diagnosis in terms of probably an IOP, or OPG, or a CBCT. You understand the volume and contours of the bone and also the density, and then you formulate your surgical plan, decide on the implant diameter, on the length, and then you begin to place that implant. And this is basically surgically driven because you're concerned about placing that implant. You wait for the healing phase. You make a second stage exposure, find out that the implant is osseointegrated well. You feel happy about it. The clinician makes the impression and then transfers the impression to the lab. The lab also takes in the jaw relations. And as a clinician, you're happy because the implant is taken up really well. But the lab calls back. You hear Shah Rukh Khan on the phone, and Shah Rukh Khan says, "Bhai, picture abhi baki hai." Your lab technician tells you, "Sir, this is where the crown needs to be in Hyderabad, and you place that implant somewhere in Timbuktu. And how do you expect me to, get these together?" So such, if not insalvageable situations, difficult situations do arise. It is because most of the implantology in the earlier stages was surgically driven. Now let us talk about a contrary approach where the prosthetics is planned first. We try to imagine where the prosthesis best suits the patient in terms of its position, the lines and contour, and then we place an implant which seamlessly fits into the processes. This is retrospective planning. And I would like to begin the webinar trying to focus on this aspect of implant prosthodontics to impress on the fact that prosthodontics does not start after an implant is placed, but prosthetics and implantology starts even before an implant is placed, for the reason that we want to avoid situations like these. You know that you've placed implants, the implants are osseointegrated and they're very successful. But eventually you find out the prosthetic rehabilitation of such implants is a mighty task, sometimes non-negotiable, right? So we want to avoid such kind of prosthetic failures. So the road to implant success starts with the prosthetic planning first, right? There is no two ways about it. You imagine and decide what is the type of the prosthesis, where the prosthesis has to go inside the patient's mouth to satisfy both his aesthetics and function. Then you do the parasurgical planning, like accessory surgical interventions like augmentation of soft tissue or hard bone, and then, and only then, perform the actual implant surgery. The implant rehab success is a wheel which runs on three spokes. The three spokes are the implant bed, which includes the hard and the soft tissue. It is the implant itself and the prosthetic superstructure and the implant occlusion that is given eventually. Coming to the implant bed, it consists of the soft and the hard tissues. That is the gingiva, the alveolar mucosa, and the alveolar base and the periodontal bone, which is all evaluation of this is directed towards achieving aesthetics and function for that patient by designing the prosthetics. So the patient is really concerned about aesthetics and the function. To you, it is about the canvas, that is the bone and the gum. But to the patient, it is about the painting on the canvas. It is his expectations. So you have to give considerations with regards to how the soft tissue is, how the hard tissue is, and what type of prosthetic option best suits that patient in terms of his demands. So to begin with, implant planning has to start with devising the type of process which best suits the clinical condition, right? And it starts with the assessment of the gingiva and the alveolar mucosa. It starts with the assessment of the alveolar base and the periodontal bone in case of an immediate extraction and placement. It also starts with what is called as assessment of the crown height space, that is the prosthetic space that is available for the patient. And of course, the assessment of the smile line, which goes a long way in determining the or addressing the aesthetic concerns of the patient. The implant bed evaluation starts in simple terms with the gingiva in determining what the periodontal biotype is, because the gingiva in patients differs from being thick to moderately thick to very thin. And these are the three different types of periodontal biotypes that you have to reckon. And in cases of moderate or thin gingiva, you often end up with problems of the implant crest module or the abutment collar showing through the thin gingiva as a grayish discoloration, right? The simplest solution for this would be to select an abutment which is, not metallic, with not a metallic hue. You have gold ionized abutments, and you also have aesthetic abutments, which could be either in peak or zirconia. This is the simplest way of negotiating that problem. Now, if you had not realized what the periodontal biotype was, this small, easy deviation would have costed you eventually in terms of the aesthetics. You also take into consideration the periodontal bone in case if it's a tooth that has to be immediately extracted and implanted, and the alveolar base. You assess the bone both radiologically and also clinically to see if there is any compromise in terms of the height, the width, or the density, and also if this tooth suffers from any periodontal disease, which might ensue with gingival recession or resorption of bone, and the type of process you had earlier decided without relevance to the bone contour could cost you in terms of aesthetics and function eventually. And we all know when it comes to the implants in bone, there is a golden rule of implant and tooth distance. The minimum distance between the tooth and implant, as we all know, has to be at least 1.5 mm. And the same has to be 3 mm between the two implants. And this disparity is because of the presence of the periodontal ligament in a tooth. And they have these sharpest fibers, the periodontal fibers, run into the bone and help support the bone. And therefore, a width of 1.5 mm is enough to maintain the interdental crest. But however, the implants suffer from the lack of periodontal membrane, and therefore they have to have a greater volume of bone in between them so that you have the interdental crest surviving, and that supports the interdental papilla, and that provides for aesthetics eventually. So this is the story behind the golden rule of the implant distances. Now, another feature that you have to remember, and I see that most of the young nascent implantologists forget and neglect, is to know what the restorative space available is. For example, even a single tooth missing or a single implant case or a multiple implant case which has a long span FPD, and more specifically in cases which are completely edentulous, you have to take the diagnostic impressions or the diagnostic cards and articulate them on an articulator and check with what is the ridge distance or the restorative space available. And with this in mind, you have to select the processes that will eventually go into the patient's mouth. The crown height space or the restorative space actually determines which type of process actually goes into the mouth. We know that the implant supported process could be fixed or removable. The fixed process can be classified as FP1, FP2, and FP3. FE1 is the fixed processes where the crown height space is just about adequate to restore the coronal contour of the tooth alone. The bone has not suffered from much of a resorption. And in the FP2 prosthesis, there has been mild resorption, and you might have to restore the contour of the prosthetic crowns, both in terms of the coronal structure and also part of the root, and that is called as an FP2 process. In some cases where the resorption is predominant and the crown height space available is greater, then you'll have to replace not just the tooth crown, the root, but also the resorbed bone. And you can't have a long process showing through the lips or the soft tissue. So you generally mask the elongated process by giving some gingival ceramic or composite. And these we usually refer to as the hybrid prosthesis. And these are planned in advance in cases where you've seen that the resorption is predominant and the crown height space available is greater than, say, 15 millimeters. Now, there are the removal processes also. They are removal process and implant supported for the reason that the patient has lost a lot of bone in the posterior quadrants, or for also the reason that the patient cannot afford a full mouth fixed rehabilitation. Now, amongst the removal processes, they are classified as RP4 if the prosthesis is completely supported by the implants, and it is RP5 if the implants are few, in the sense 2 or 3 in the interforamina or the intersinus region, and they support a removal process, then it becomes an RP5. Another important aspect that you have to assess in terms of a patient is his smile line, because the patient, especially if the teeth that are to be replaced are in the anterior zone or the aesthetic zone, and you have to assess the patient's smile in terms of the amount of incisal or labial show. Some patients have a low smile line with just the incisal edges showing or the up to the middle of the labial surfaces showing, whereas some patients have a median smile line where the smile upper lip is retracted such that it exposes the gingival zenith or the interdental papilla. And then you have the high smile, the gummy patients, which are really difficult to cater because they smile, the whole world shows. You know, the lip is retracted to close to around a centimeter or two above the gingival zenith. So a proper assessment of the smile line is also important in the inclusion of the factors of smile line and also the crown height space. The process can be FP1, like I told you, where the process only replaces the crown, like in this case, an ideal easy case of immediate loading, the central incisor, or in some cases, the patient's aesthetic demand is high and he's got a very high smile line and deficient bone. You might have to, you know, collaterally approach the patient with both the implant placement and guided bone regeneration to provide for an FP1 process. And this is possible when the crown height space is around 8 to 12 mm alone. This is another case of socket shield where the patient had high aesthetic demands and we had to give an FP1 process, right? So I have imagined the process first. I knew that it had to be an FP1 processes, and therefore I did extraction, and we had progressively loaded with temporaries. The temporaries were contoured such that you could give a good gingival profile with a gingival zenith, which is relatively the same as the contralateral tooth. And this is an FP1 process which replaces the crown alone with a crown height space of 8 to 12 mm. This is another case where we gave an FP2 process because the patient had a low lip line. He didn't have much of the root part of the teeth showing, and there was generalized recession, as in this case. And in this case, we had an imbricated central incisor, and we had given a temporary tooth, a temporary crown immediately, which is screw retained. Now, FP2 processes are indicated in crown height spaces which go up between 10 to 15 millimeters, and they restore the contours of both the crown and the root. And these are the cemented bridges, multiple long span bridges or full mouth, full arch rehabs, which are also FP2 for the reason that the patient had a low lip line and a crown height space of 10 to 15 millimeters. An FP2 process is the one which replaces the crown root, like I said, and it's not confined to the aesthetic zone or the anteriors alone. Sometimes the patient not just has a low smile line, but he has a very wide smile line where the molars show. In such cases, you could give in a FP2 prosthesis. The FP3 processes are the ones which replace the contours, the crown, root, and the lost bone. Like in this case, the patient had a high lip line, and we had a hard and a soft tissue defect, and therefore we had to give him a FP3 process where I had to ask the lab to give the gingival ceramic also, and we used an angulated screw channel. And FP3 process indicated where the crown height space is large. That is because the resorption of the bone, and the crown height space is greater than 15 millimeters. This is another full arch restoration, a very tough case with lost vertical, where we have given an FP3 process with non-axial implants in the M type of all-on-4 configuration. Coming to the removal process again, like I said, if the removal process is supported by the implants and the implants entirely, it is considered to be called as an RP4 prosthesis. And because it replaces the gingival contour and also the clinical contours of the teeth in the prosthesis, it can be used in any smile lines, especially when the crown height space is greater than 15 mm. And then you have the RP5 prosthesis, which derives a part of the support from the implants and part of the support from the denture-based tissues. And the attachments can vary depending upon the profile of the crown height space available. You have the high profile attachments like a baronet clip, and the low profile attachments like, or moderately high profile attachments like the O-rings or the Dallabone attachments. And in cases of crown height spaces which are slightly less than you'd anticipate in a crown height space of 15 mm, you have low profiles like locators, right? So this is an RP5 process for the reason that it is removable and it is supported by both the implants and the denture-based tissues. And this is one case of a rare case of a geriatric adult cleft, which I addressed with an RP5 prosthesis, where, you know, the prosthesis is removable and it is supported by these Dallabone attachments, and the support is drawn also from the basal tissues. So in summary, identifying the type of prosthesis, taking into consideration the various clinical factors is important. And the prosthesis can be classified as fixed or removable. Amongst the fixed, you have FP1, and it is indicated when any smile line, like low, middle, or high, and it only replaces the crown. There is the FP2 prosthesis where you have anticipated bone loss and there is recession, and the prosthetic contours replace the crown and also a portion of the root. And this is indicated especially in patients who have a very low lip line. If they have a smile line which is moderate or high, you do not want an FP2 prosthesis because it is unsightly. The root part of the prosthesis shows. And FP3 prosthesis is is not indicated in a low slip line because you could go in for any of the prosthesis. This replaces the crown and the gingiva and the bone by adding gingival ceramic or gingival composite. And there are the RP4 and the RP5 prosthesis like we discussed. So the decision-making summary when it comes to the prosthesis, and believe me, I can't overemphasize enough that the prosthetics has to be planned first, depends upon various factors, which include the available bone, the crown height spaces, and also the finances of the patient. And then you decide if it's going to be fixed prosthesis or removable, and you assess the smile line and the patient's aesthetic demand and decide of which of the prosthesis best suits the patient in terms of function and aesthetics. Then we come to the implant proper, that is the implant superstructure, which includes the abutments themselves and the prosthesis. Now, I will just rush through the different types of abutments and components that are available. We all know what they are. It starts with the healing abutments. The healing abutments can be used in the first stage while you place the implants to make it, a single stage surgery, or they could be used after uncovering the implant in the second surgery to form a nice gingival cuff and make it restoration friendly. There are temporary abutments supplied by your implant companies where if you intend to give immediate temporization for the reason that you want to maintain the gingival contour or engineer the gingival contour or the emergence profile, you can use this temporary abutments, which will eventually be replaced by the permanent abutments. And there are the regular stock cementable abutments for the cemented prosthesis. These are of different types and they come in different angulations also, the stock ones with or without collar, and of different materials with or without a tie base. And you have aesthetic abutments which have contoured gingival collars to accommodate the aesthetic emergence profile, both in the anteriors and the posteriors. Then you have patient-specific abutments, which are generally screw retained. These could be tie-based UCLA or castable abutments, tie-based zirconia abutments, or abutments with machined collars. Then for the RP4 and the RP5 prosthesis, you've got the implant overdenture attachments, which can be either the locators, the O-rings, or the Dallabone attachments with a ball and socket joint, or there could be just friction grip like the conus abutments from ankylosis or dentsply. The prosthetic aspects involves the impression copings, and the impression copings are of different kinds, open and closed tray, and these impression copings help in recording the three-dimensional location of the implant in the patient's jaw and transfer it into the working cast. And then you have the implant analogs, which are the substitutes for the implants in your lab cast or lab working cast. Prosthetics has a blessing in terms of CAD/CAM technology, where it increases the vista of the implant abutments and makes them more friendly in terms of aesthetics by giving good emergence profile and customizing it to your particular case or a particular patient in what are called as customized or milled abutments. They come in different materials, and this has made customized prosthetic solutions take a giant leap thanks to the milling procedure. There have been queries in the registrations about multi-unit abutments. I'll just rush to them, but we'll discuss it at length later. There are multi-unit abutments with different angulations which spread over from 0 to 45 degrees. And there are certain companies which have made multi-unit abutments even to 60 degrees to cater to the pterygoid and zygomatic implants. These are short profile abutments, and there are two-piece abutments. They're called multi-unit for the reason that they have multiple pieces, right? So it is a two-piece abutment. And the advantage is that they can cover up for divergence between multiple implants to a degree of close to 40 degrees, which is seemingly impossible without the presence of the multi-unit abutments. They have variable collars to accommodate the mucoperiosteum, the biggest advantage that they offer is that the non-parallel implants can be made parallel to the prosthetic or restorative level, and the process can be retrievable for the reason that you can unscrew the process, you can maintain it, clean it, polish it put it back, and in case there are any chipping or fractures, you can also repair it and put it back into the patient. So it is very serviceable, and that is the biggest advantage that these multi-units offer. And much of the non-axial cases that are done, or anybody does for that matter, all in 4, all in 6, are made possible together with the multi-unit abutments, because they give you a prosthesis which is both serviceable, I mean maintainable, and also predictable in terms of how the prosthesis behaves on a long-term basis. Then we come to the heart of the matter of implant prosthodontics, that is the implant abutment connection. This is something that we tend to ignore, but all the experienced practitioners will agree that this is the weakest link in the entire system, right? Now, if the prosthesis underloading or biomechanics suffers from situations such as a prosthetic screw loosening or an abutment screw fracture, or greater complications like the implant crest module fracture, it is called as a flowering fracture. I find that happening often in Austin, is because of the nature of the implant abutment connection. Now, the implant abutment connections are needed to be strong, and they are needed to provide an anti-rotation that decreases the torque forces on the implant proper. They need to distribute the stress properly, and the implant abutment configuration should have an accurate fit, no compromise there. It should provide for zero micro movement, and this prevents the crestal bone loss, right? And it should have a biological seal so that there is no biological bacteriological colonization. There is zero micro leakage, and most importantly, they should be retrievable. The configuration should be such that you could always retrieve it for, as I said, service and management. But all of these 6 important requirements of an abutment implant configuration can go for a 6 if the processes that goes above it is not passive. If the superstructure is not passive over the abutments, irrespective of the implant abutment connection, it is bound to complicate. So it is important that implant abutment configuration has to be scientifically engineered. With good knowledge, you have to decide on which implant abutment configuration to choose. But what is also important is that process which goes over these abutments need to be passive. Now, there are different configurations available. Now, the 3 major categories belong to either the external hex or the external hexagon, the internal hexagon, or the Morse taper or conical connection. You have the external hexagon, not very popular here, but still popular in the Far East countries like Korea, Taiwan, and Japan, and also China. I've seen like the Nobel MK2 Groovy and the Maestro implants from BioHorizons. They still have external hex. The problem with external hex is that it often causes a greater amount of crestal bone loss and screw loosening. You have non-indexed connections called the conical connections, like in Astra Tech implants. You have the tri-channel connections, such as in Nobel Replace. You have the internal hex, which is a universal connection, which is most popular with us, as in most of the implants that we use. But we are moving towards a connection which is indexed conical connection, because these seem to preserve the crestal bone better and cause less screw loosening. And like you see them in the tapered internal BioHorizons and the close fit in the add-in. And you have patented connections which are distinctive to a manufacturer, like the torque connection, torque resist or torque fit connection in Straumann, and a very unique tube-in-tube as in Camlog implants. So irrespective of what the implant configurations are, you have to have proper knowledge. But all implant abutment configurations suffer from screw loosening and probable screw fractures and micro movement, which could result in implant crest fractures. So one company, Bicon, has come up with a screwless or frictionless friction fit abutments. Here you don't have a screw. The abutment is just tabbed into the implant. It gets cold soldered. And what is great is that they can achieve with great precision a true Morse taper of 1.5 degrees. It cold solders the abutment to the implant. So there is no question of any abutment screw loosening or fracture. But the problem is the abutment is not retrievable. The process might not be retrievable for service or maintenance. Irrespective of the implant abutment connection, I emphasize on the fact that if you do not provide for a passive prosthesis, any implant abutment configuration is bound to fail at the connection level. We come to the implant prosthesis now. I'm halfway through the time that I've been allotted, thankfully. And we come to the implant prosthesis proper. And when we talk about the implant prosthesis, it can be either cement retained or screw retained, right? And we will not go into the depths of each of these. I would like to try to discuss the advantages and disadvantages of each of these configurations. To start with the cement retained restorations, they're very popular with us for the reason that they're low cost, right? You just have the luting cement and the lab work becomes so much more easier. It provides for reasonably good aesthetics. It has a passive fit, like I told you, which is very important. And the occlusal table is adjustment for the reason that you don't have an access hole, or it doesn't compromise the occlusal integrity because of the presence of an access hole that a screw retained prosthesis has. And the disadvantage, the main disadvantage, if any, is that it is not retrievable, or it is retrieval with difficulty because you have to tap it open, or perforate the crown to enter into the access channel. And because it's cemented, you don't have control over the cement leakage into the peri-implant sulcus. And this extra cement can cause peri-implantitis and bad tissue response, and therefore the tissue response is questionable. And you can use a cement retained prosthesis only in cases where the crown height space is such that you have at least 5 mm of the abutment inside the mouth. Coming to the screw retained restorations, they are my favorite for the reason that they are retrievable. You can service your process at any point in time. You have a problem with a loosened screw, you can always tighten it by opening into the access channel. You do not have a problem of excess cement or cement leakage, and therefore the tissue response is much better. And you can use it in compromised abutment heights, where the abutment height needs to be reduced to less than 5 millimeters. But the disadvantage is that it involves high costs. It can compromise the aesthetics, especially in the anteriors, where the screw and the access screw channel, opens out on the labial, either cervical or the middle. Passive fit is difficult, especially in multiple implants, if you have a hex connection, and that is the reason why the lab tends to recommend non-hex connections to give that passive fit. But with a hex or a very exacting implant abutment configuration, a passive process is very difficult with a screw retained prosthesis. And because you have a screw channel in the posteriors, which usually opens up in the occlusal surface, it compromises the occlusal integrity and makes the occlusal adjustment a little difficult. So we have come up to understand the best of both worlds, and now we have a process which has the advantages offered by both the cemented and the screw retained prosthesis, and it's called as a screw cement retained prosthesis, right? And it provides you the advantages of both passivity and retrievability, which is individually seen in each of the earlier implant process systems, but not together. But the screw cement retained process can now provide for passivity and retrievability. Coming to the implant superstructure materials, this is an enormous topic, so I will just touch and go. So the implant superstructure materials, I classified them to the veneering materials, which are usually non-metallic, and the strong substructures, which are metallic in nature. The non-metallic veneering materials are usually polymethyl methacrylate, composites, layered ceramics with the lithium disilicates. It could be a fiber reinforced composite. It could be any of those polyether ketone polymers like PEEK or polyaryl ketones, and also ceramic infiltrated PEEK polymers like BioHPP, which is bio high performance polymers. Now, graphene is a new introduction to the non-metallic superstructure, because it is considered a miracle material. It is claimed, depending upon how it is manufactured, to be 100 times stronger than even steel. And there is a continued research, and there are companies which have released graphene as a substructure material for prosthesis. Let's see how it goes. And amongst the metals, we have the lesser popular metals like the nickel chromium and cobalt chromium, because they add the gray issue and add a tremendous weight to the process, especially in terms of full arch rehabs. And you have the lighter materials in titanium, and you have the aesthetic materials in zirconia, right? And the veneering and the substructure materials can be used in any number of combinations. And I'd like to refer to them as what are called as hybrid cocktails. You can have, the cobalt chromium with acrylic, with composite, with ceramic. You can have PEEK with lithium disilicate. You can have titanium with zirconia. You can have, the polymers with polymers, that is the BioHPP or PEEK with the composites. So there is a whole lot of combinations that are possible in the superstructure given the materials available. Coming to the prosthetics proper, which scares a lot of practitioners, general practitioners and implantologists, that is the impression making. Now, this is a last topic. I'll just run through it fast. Now, the implant impressions are at either the abutment or the implant levels. The abutment level impressions are either direct technique or indirect technique. The fixture level implants are either closed tray or open tray impression techniques. At the abutment level, the direct impression is much like a prepared tooth or a bridge. much like you prepare a tooth and take an impression. You, after the implant is uncovered, you place a suitable abutment, you mill it inside the mouth if you are the adventurous kind, or you take the abutment, put it on an analog and trim it chair side to the contours that you want, put it back on the implant and take an impression like a regular impression. You have a working cast from that impression, and a prosthesis comes from the lab and you cement it onto the abutment after indexing the abutment. Okay, so this is a simple direct impression, not very accurate, but only indicated for cementable prosthesis. Then you have the indirect impression at the abutment level. Now, some implant companies give you what is called as a ball top screw. Okay, the abutment is placed on the implant and the ball top screw is fixed on the abutment and impression is made. The impression is retrieved, the ball top screw and the abutment still inside the patient's mouth. They're removed from the patient's mouth and an implant analog attached to the abutment and the ball top screw and returned into the impression, and a cast is poured. So you have a working cast. And then there are certain companies which supply you what are called as snap-on abutment transfers, which are either metallic or plastic snap-ons, which snap onto the abutment. They're indexed. And when you take the impression out, the snap-on abutments are a part of the impression itself. So you take the implant abutment analog and place it into the snap-on uh, transfer, and then get your working cast. This is the indirect impression at the abutment level. Now we come to the implant level impressions. I'd like to take a scenario where you have multiple implants so that you have a better understanding. So the open tray impressions are called open tray because the tray has strategically placed holes. And why are they there is because you have implant transfers which are indicated for open trays. These implant transfer copings are usually longer. They have a long retaining screw which move away from the superior surface of the transfer copings. And these transfer copings have pronounced retentive features. Why is that? Is because when the impression is taken, the impression material flows into these undercuts and they help retain the impression copings within the impression. So when the impression is made after these copings are fitted onto the implants, the screws come out through those strategic holes that you've placed inside the impression tray. You unscrew the retaining screws, then take the impression out. The transfer coping becomes a part of the impression. You put the analogs, bind the screw, and then pour your cast. And this gives you exact working cast where the implant analogs are placed in the exact three-dimensional position as the implants exist inside the patient's mouth. This is true with open tray for the reason that the implant copings are carried with impression, and also for the reason that the tray has to be open to unscrew. Now we have the closed tray impressions. The closed tray impression copings do not have pronounced undercuts. They have undercuts, but they are moderate. And they have the screws, retaining screws, which are not popping out of the impression coping. You attach them to the impressions inside the patient's mouth. You take the impression with a tray and you remove the impression after it sets. The impression copings are still attached to the implants inside the patient's mouth, unlike here, which they come out with impressions. Now, you retrieve the impression transfers, the closed impression transfers, you attach an implant analog and then subsequently place the implant transfer coping composite back into the impression and pour your working cast, right? So this is the difference between an open and a closed tray at the implant level. Since we're discussing impressions, let us continue with the prosthetic workflow. Once the working cast is made, you have to make sure that the impressions that you've made are actually accurate. Otherwise, your prosthesis is just not going to fit, right? Much of my postgraduates suffer from this. So the lab has to give you a verification jig. This jig will tell you if the impression that you recorded is accurate, and the lab cast, the working cast, has the analogs in the exact position as the implants exist inside the patient's jaw, right? So the lab prepares a jig by running through dental floss across the transfer copings or the temporary abutments, and then uses pattern resin to join all of this. This jig is then sent to the clinician. The clinician tries this jig inside the patient's mouth with what is called a Sheffield or a single screw test, where the jig is placed inside the mouth, a single screw is engaged, and the entire process should fit without any gap. You probably need to take an OPG to confirm that. And you go about adding one screw from either ends and come back to the center. If at any point of time you find that any of the screw is not binding, it's not going in passively or is not going completely, then you know that the impression has gone wrong somewhere. So you section the jig at the implant that is giving you trouble, the impression where it has been recorded inaccurately. You section the jig, make it passive, and then you bind the jig together with some self-cure acrylic and send this repair jig back to the lab, where the lab makes the necessary corrections in the cast. And now you are sure, with the jig having confirmed, that the cast and the patient are at the same plane or the same level. Now, what the lab will do is prepare a bite rim, and this bite rim could be screw retained. And this bite rim or the record bases are introduced to the patient's mouth. They're engaged, the jaw relations recorded, and returned to the lab. The lab articulates its cast and then prepares the processes either for the trine or for the complete processing and cementation eventually. So I hope it is clear so far in terms of the prosthetic workflow. Digitization has opened up not windows but enormous doors, to the way prosthetics or the implant prosthetic works. Not just the prosthetics, but how surgery works. It has made the entire system so easy and successful that things have taken a huge leap, almost a paradigm shift in way implantology is practiced. So there are impression-less processes now. Imagine all those clinicians who were really scared about all these open tray, closed tray, direct, indirect abutment, fixture level impressions can now just go ahead, buy or rent an intraoral scanner, have a scan body for the implant system, place that scan body on the exposed crest module, scan intraorally, uh, feed it into your computer software. The computer software and the technician sitting with that designing software will now design the best abutment that suits your patient given the mesiodistal and the buccolingual dimensions. It gives you beautiful profile, and it also mills your process which goes and fits on this abutment accurately. So now you have to just scan, and then you have your abutment and process sent from the lab, right? And these are called as impressionless customization. So it's like a blessing for all of us. So most of us now find ourselves in the present in 2021, right? Now, when we started implantology, when I started way back in 2000, there was a lot that I wanted to make things easier for me. But the present postgraduates and the practitioners are at an advantage because they find themselves at the confluence of the present and my future then. We are at a time where, the present and the future are blending in. Now, we promise, or we can go ahead and promise the patient's teeth in an hour, right? This is possible because of the digitization of the surgical aspects and the prosthodontic aspects and blending them together through computers. There's so much the computers can do. The diagnostic CBCTs can now be used to capture the DICOM images, and these DICOM images could be transferred to a computer. Then you have the topographical record by creating what are called a standard tessellation language or STL files with an intraoral scanner or a tabletop or a lab scanner, which records the contours and surfaces of the teeth and its contiguous structures and sends it back to the same computer. And then you have a weaving software or a third software which integrates the DICOM files with the STL files, and it helps you design or place virtually the implant where it is most ideal and away from all the important structures. And then it also helps you to design a prosthesis which will go on this implant, and it becomes a part smoothly of the articulation that exists inside the patient's mouth. That is, the occlusal surface immediately blends to the occlusal scheme that you want inside the patient. You have these weaving softwares, which are like planning softwares or the weaving softwares like from Blue Sky Bio, 3Shape. There is the Romexis from Planmeca. There is the Implastation, where Implastation and Blue Sky Bio are available free on the net. I'd suggest the postgraduates download these and play around them so that they get a hang of how things have changed. Now, with the advent of CAD and CAM, that is computer-aided design and computer-aided milling, the lab can provide you with surgical guides where you could, with not so much of gullibleness or tension that we've had when we started implantology, you can have very predictable surgery. And the lab also gives you the prosthesis in the abutment by milling whatever material that you think is right and sending it across to you. So at this point in time, you have the surgery, which is completely guided, and you have the prosthesis, which is already engineered inside the patient's mouth, all in probably an hour. And this is how implantology is going to be practiced in the future. It's not about waiting or doing. It's about understanding that this bone is good enough for immediate loading, and then going ahead and planning your implant placement and also the process. Mind you, this comes with statutory warning that the patient should have the system conditions and also the bone which is conducive to such manipulation, right? That is in terms of immediate loading. So I'll end with a short video of 2 minutes. I was given 40 minutes and I'm thankful that I could finish in 40 minutes. This is a 2-minute video that I'd like all our young implantologists to watch. And this is how we are headed in the future. So this is the times where implant was challenging for most of us, two-dimensional radiographs and, diagnostic casts. We had to have a whole pile of them. And if the impressions are inaccurate or the OPGs, which had tremendous magnification, compromised our planning. And there are multiple visits, the patient comes, goes, comes, goes, comes, goes, comes, goes, and the patient is exasperated and you're embarrassed and you just say bye-bye to each other with sloped shoulders, although the job was done. But today, there is a better way, and that is by going digital. How is it important? You just need to scan. There is no messy work. The patient isn't scared. The patient goes and gets his CBCT scanning. This gives you the hardware. This gives you the software. And both of them are digitally put together through a weaving software like Implant Studio from 3Shape. There is the lab, the dentist, and the surgeon together who can see the same data, plan the process first. You will see this here, the process is planned first, and related to the process, now the implant position is taken care of so that the process and the implant blend in seamlessly. And once that is confirmed, a surgical guide is designed, and the surgical guide is then milled, right? And it's not just a surgical guide. Along with it, come a lot of other features too. Now, your lab can not just provide you surgical guide, it can provide you the crown. It could be temporary or permanent, and it could give you milled abutments, which just suits the implant the way you've placed it. And the entire package is just milled to you. What has been your contribution so far? Just an intraoral scan and some help with the designing. The patient comes, you have the surgical guide, you place an implant where it should go, no worries about being off center. You have the abutment and the crown delivered to the patient within that hour. So you have just a consultation, you have the implant placement and the restoration, and then the third visit is just about the checkup and recall. Patients are very happy because there's so much done in so little time, and the word of mouth spreads, you have more patients and you have more dough in your bank, right? So this is where the implantology and implant prosthodontics is headed. But all said and done, if you do not have the proper knowledge of the basics of implantology, you might end up being embarrassed all the same, because the lab should not govern your decisions, but it is your knowledge that should govern the decisions, right? Now, when we were practicing implantology in the early 2000s, we always looked for technology, both in biosciences, and even engineers look for technology in the future, which provides them for ease of deliverance, ease of execution, and also predictability, because only when things are predictable, then you can be confident of what you're doing now, because you know what the result is going to be and how it's going to last. So that is what the future held for us, at that point of time. And for the people practicing implantology now, allow me to tell you that the future for you has already arrived, right? Thank you for your kind hearing. And with that, I'll stop sharing the screen and give my mic to the moderator, Ram Babu. I'm sorry if I've rushed to the presentation, but I guess I'm just 2 minutes over time, Ram Babu. Thank you.
Thank you so much, sir. As expected, that was an excellent presentation from you, sir.
Thank you. Thank you.
Very comprehensive. And from here onwards, it's a Herculean task to address all the aspects of implantology, but you did a great job to review all the important topics, and you could fit everything into that 40 minutes. That's a great job, sir.
Thank you. Thank you, Ram Babu. I hope it helped.
Yeah, yes, sir, definitely. Now let's, sir, before going to the case presentation, I just want Mahendranath Reddy, sir, to comment on the presentation. Sir, please.
Congratulations, Sudhir. I think you have covered all the topic. Excellent.
Thank you.
I was
Thank you, sir.
actually
Thank you so much.
Thinking of whether you will cover the prosthetic space and things like that. That's what I prepared just to enhance your presentation.
Thank you so
much.
much.
You covered the basic things, which is prosthodontic dictums, prosthetic space, screw levels, screw retained, and things like that. Hope all the people who are there have understood that. If you
I really
have any
hope so, sir.
doubts, the panelists are there. We, along with Sridhar and moderator, I think we'll try to help you out in understanding it a little more. Thank you.
So now let's look at the same thing from a clinical perspective. So we are planning some case reports now. Hope this will answer most of the questions from the attendees. Now I request Dr. Vasudha Madam to present some case scenarios.
Yeah. Thank you, Ram. I'm just sharing.
And please share your screen, Madam.
Yeah.
Yes.
So, a very good evening to one and all. And thank you, Vivek sir, for that warm introduction. And I would pay my respects to the President, Dr. GC sir, and our scientific convener, Dr. Vivekvardhan Reddy sir, and esteemed panelist, Dr. Mahi sir, Dr. Vijay sir, and my senior and friend, Dr. Sudhir. Today, I would like to present 3 clinical scenarios. Basically, I would like to impress upon the importance of the restorative space or understanding of the restorative space before jumping into any implantation. So visualizing the final processes before going into, as Sudhir already stated, before going into restoration, before going into implantation, it is very important for us to visualize the final processes. So here the present case here looks like a common regular, if you mask all the implants present here in this OPG, it looks like a normal crown and bridge where all the crowns have been cemented onto the implant, onto the natural tooth. So how could this come across? So I would like to stress upon the treatment planning which has been done in this case. So initially we have gone for the fabrication of a complete denture first. So which was again duplicated way back, it was done in 13 years ago, wherein manually it was duplicated by casting. Acrylic denture was fabricated. Maybe nowadays we can get a 3D printed or CAD-CAM milled duplicated dentures. And all the prospective implant sites were using a milling machine, all were drilled, grooves were created in those prospective implant sites. And a multi-purpose template has been fabricated here. Now this has been used as a radiographic template, and you can visualize rectangular bullets which have been seen on this, and the topmost part actually helps us in understanding the occlusal plane, and the bottom part and the margin from the bone helps us in visualizing the amount of mucosa thickness also. So this was again used as a surgical guide, and also this was again helped in locating the emergence or locating the implants during the second stage surgery, and also this was again used as a customized open tray and for open tray impressions with analogs. So by fabricating a denture ahead and using it as a template and visualizing the amount of bone or whatever is lost. Now in this case, let us see in the scenario 1, there is only loss of tooth structure. There is no much loss of any bone. Now this wasn't very middle-aged, tall and well-built person with good muscular activity, and we expected a lot of good occlusal forces in this scenario, and multiple implants have been planned because he had much available bone, and this was a totally restorative driven implant positioning, and this is a normal standard one which is given by Mish, or it can be varied. An important clinical aspect in this is we have not gone for splinting of all the implants in this case, because sectioning of the implants, especially in the mandibular region, aids us in avoiding, because mandible is a elastic one, and because of the hyperactivity or activity of the masseter muscle and the medial pterygoid muscle posteriorly, we'd always flex the mandible during our masticatory forces. So that may cause the cement breakage and prosthetic failure. So that can be counteracted, and also sectionally repair of the process becomes so simple if there is any uneventful thing happening. So this was a simple case wherein only a white aesthetics has been restored. So let us go to the case scenario 2. In this situation, the patient reported with this situation, there's a female patient, wherein in the mandibular arch, most of them were lost due to periodontitis, and you can see again the same kind of template has been fabricated, and these cylindrical bullets. Now you can see from here to the lower border of the mandible, we can see the amount of soft tissue here. I mean, sorry, the margin or the crest of the bone, you can see the amount of soft tissue here and also the occlusal plane here. So if you visualize in this picture in the center, there is about 18 mm of bone loss or about 20 mm of bone loss in the mandibular region. So this definitely needs restoration of both white and pink aesthetics here. And in the maxillary arch, we had done a total extraction because of secondary caries and fracture of certain tooth and repeated decementation. So this needed a regular crown and bridge restoration. So this is how, though the occlusal plane has to be evaluated before going for any restoration, and the type of processes has to be planned. That is what I want to stress in this scenario. But if you critically appraise this case, the maxillary and mandibular regular crown and bridge has been restored. Normal implants with placement of cement retained crowns, which are again sectioned in the maxillary and the mandibular. The patient was very happy, but if you critically, or if I critically appraise my own case, now I feel I'm not at all happy with this, because you can see abnormally long crowns in the mandibular. This case could have been treated well with an hybrid processes, wherein you can give good pink aesthetics and build the bulk with all the gingiva with lower weight materials and give a good clinical crown height and helps in maintaining the prosthesis. So this is how we could come across. This is how the implantation has been carried out in this case. Now when you come to the clinical scenario 3, now this clinical scenario, we can visualize there is excessive bone loss, very minimal attached gingiva. So we have planned for an all-on-4 case, because again we have fabricated a denture in this case. That is, visualizing the final end result was more important for us. So, and understanding the available restorative space. Now it was about 20 mm in each arch which has to be restored. So definitely it tells us we have to restore a lot of pink and white aesthetics, and the amount of bone being less. Maybe we would have gone for a maxillary sinus lifts, and which takes a longer time. We have opted for an all-on-4 in both maxillary and mandibular situation, and we have gone for a dual scan technique in this case, wherein the dentures are given markers in different planes. These are the commercially available markers which are present on the right side, which can be glued onto the denture, or that can be fixed. Composite balls or small globules can be bonded onto the denture in different planes on the flanges, and this is the dual scan which you get. This is overlapped on a scan by the CBCT guy with the scan made without any dentures, and that's how. And restoratively driven virtual surgery can be done. This is how we have planned the implants, and the emergence of as we all know, the emergence of these has been kept as posteriorly as possible, so that we can minimize the cantilevers, and this helped in the fabrication of a surgical guide. The importance of this restoratively driven implantation is that we can give the emergence or the access holes more palatally. If it was a freehand surgery, we are not sure that you are going to place these more palatally, so that anesthetic screw access holes labily could be prevented. Now this is how we have gone for it. All the tiltal implants have been made straight with the help of the transmucosal abutments, which are as described by Sudhir in the previous session. This is how the mandibular has been proceeded. Now this is how with the temporary or healing screws which have been placed over these all the implants. And these are the impression techniques. These are the splinted open tray transfers which have been splinted. The importance of it was already discussed, so that we want to transfer the positions of these implants more rigidly, or the positions of these implants can be duplicated onto the cast with the help of these. Now we have carried out a trayless impression here, and we can see here in the first picture in the maxillary 2-1 region, you can see the implant is more labially placed. I would come to it in my next later slides. This is how we could achieve the models, and jig trial as stated, it is very important. The splinted ones were fitted onto the implants intraorally, and Sheffield test has been done. wherein it has to be passive even if you screw in at least any one of these jig abutments. Once it was confirmed, CAD/CAM designing, and in this case DMLS framework with layering with ceramic was planned. The metal trial. Metal trial has to be appreciated by taking regular radiographs. Even the final process has to be appreciated. If any marginal gap has, the whole framework has to be adjusted or should be done until satisfactory or has to be repeated to get a prosthodontic success. Otherwise, screw loosening or prosthetic failure, and in the long run, bone loss and implant failure will result. This is how the prosthodontics would dictate the success and longevity of the implant. So this is how we could get final processes, final hybrid processes wherein the bulk of the gingiva was actually nicely covered, and also the pink and white aesthetics have been justified. Now this is how the fit and the final process. This is the occlusal where the access holes in the anterior region were tried to be in the more palatal region and the occlusal surfaces. And this is the view. And if I critically appraise this situation, I can see this black triangle in the even in the smile zone here. This is because the implant has failed because of some uneventful situation, and I had to do a freehand surgery in this case in the 2-2 region. And because it was a freehand, it has come more labially depending upon the available bone, and this is how my aesthetics has been affected. So a prosthetically driven implantology would always help us in getting us a good result, and even this could have been avoided if it was placed more palatally. And we can see nice fit over the over this TMA abutments. The margins can be well appreciated in this scenario, and this is the left one, and this is how. And I proudly present here this case because this was the latest case which was done in our GDC, our own GDCH. And I thank our HOD for giving us or was keen in developing implantology in our department and has done it. And proud to present is at this GDC alumni webinar. And this is how it's the team which we have successfully could do it. This is how, with this I end my presentation. Over to you, Ram.
Well, ma'am, thank you so much for the presentation. That's a very nice presentation, ma'am, actually, of when and where to choose the different processes, considering the pink aesthetic especially. I think that explains when and where to choose different types of process. And it's so nice of you to critically appraise your own cases. It happens when you go back and look at our own album, the old album. Sometimes we feel we should have done it in a better way. That happens when we progress, right? Well, to the audience, if you have any questions, you can leave the questions in the Q&A box, and we'll be happy to direct this to the panelists. So with this, I would now request Vijay Srinivas sir to come up with his presentation.
Is it okay, Ram?
Yes, sir. Audible, sir. Yeah.
Good evening, one and all. Good morning to the Westerners who are watching this webinar. First of all, let me thank Dr. Vivek, scientific convener, Dr. GC, president alumni, and my co-panelists, Dr. Mahendranath Reddy and Dr. Vasudha, and moderator, Dr. Ram, and today, show stealer, the main speaker, Dr. Sudhir. My God, Sudhir is like a bullet train. Even the internet couldn't stop him. It is just trying to pause him. Excellent presentation, Dr. Sudhir. Anyway, I am going to talk about two cases. One case is where there is a periodontally compromised case where I had done a full mouth extraction and placed 6 upper and 6 lower implants. And then it is a guided surgery. And then the final process is done by a titanium framework where there is a visual layering of the composite is done. This was done about 6-7 years back. That time this titanium milling is new and the layering of composite is also new. Coming to this second case is an immediate loading protocol. The first case is a delayed loading protocol and the second case is a immediate loading protocol. Coming to the first case, this patient Sharada who came to us, she's about 46 years. Her chief complaint was she's having a inability to chew proper food, and then all her teeth are mobile, and then she's having halitosis also. Her main demands is she wanted to go for a fixed restoration, which is more functional and aesthetic. Upon clinical evaluation, we could see a lot of generalized fluorosis with chronic periodontitis, lot of loosening of the teeth, drifted teeth, gingival recession, and halitosis. So we had taken a OPG and then we could see a lot of vertical and horizontal bone loss. Most of the areas we could see furcation involvement. And then we had taken a CBCT also just to assess three-dimensionally what is the amount of the bone loss and where all large defects are present. So we wanted to go for a full-fledged treatment for this patient. And any patients who comes with this problem, we had to give a total comprehensive treatment plan to the patients, starting from the removable dentures. First is we had to go for a complete full mouth extractions. And then we had to give an option of going for a complete denture. And if the patient is not much interested in the complete denture, next is semi-fixed processes like 2 implants or 3 implants, ball over denture, or 4 implants and a bar over denture, what Sudhir has explained in his presentation. Otherwise, you might as well go for a 4 or 5 or 6 implants and a hybrid process, which is totally a fixed process. So here the patient wanted to go for something totally fixed without any other options. So we have planned for a full mouth rehabilitation. For the final process, we have different options of going for an acrylic process or a PFM process or a processes which is layered with the composite. And the base material can be either with the nickel chromium or cobalt chromium or titanium or bio HPP or the PEEK, which are the latest materials. Upon these frameworks, we are going to layer the composite for this particular patient. So this is a composite material which is layered, white and pink composites. The basic advantages of this composite is it is highly aesthetic, it has high strength, and it has low weight. Only disadvantages is it is very expensive and it is technique sensitive and it is more time consuming. We have jotted down a treatment plan for this patient. We had done a pre-surgical phase where we have taken a consent from the patient and consent from the physician and went ahead with the total extraction, full mouth extractions we had. Immediately within that week, we have given interim process, a complete denture we have given, which is soft lined. Then later, after uneven full healing of after 3 to 4 months, we had taken a CBCT just to see how is the bone formed where we had done the extractions. And then we had taken a CBCT with the radio opaque markers in the denture just to see, just to send these STL files to the lab people to fabricate a surgical guide. Usually when we send these casts and the STL files to the lab people, they'll play around with the implant software. They'll try to place the implants virtually within the jaws to see where exactly the available bone is present vertically and horizontally. Then and there, they'll discuss with you where exactly to place the implant in the key implant positions and where is the amount of the bone available vertically and horizontally. According to your specifications, according to their planning, treatment planning, finally, they are going to send you a surgical guide. Along with the surgical guide, they are going to send you a prescription also, just to say where exactly you have to place which implant and what is the length and the width of the implant. So this is the surgical guide we got from the lab people. You can see occlusally there are whole sleeves where exactly you have to do osteotomy while while fixing it in the jaw. And then 3 other holes, what you can see here, these are anchoring holes to keep the anchoring pins into these holes. So this is the maxilla and the mandible. We got 2 surgical guides stents from the lab. This is an extended surgical kit. That time, this is a universal surgical kit. Apart from this, only Noble Biocare has having the surgical kit, guided surgical kit. Apart from that, only this is the company into K kit. It is a universal guide kit. Nowadays, each and every implant company has their own surgical. This is called as an extended surgical kit because the drill length is more. Because if we had to place a 10 millimeter implant, the extended drill we had to use about 18 millimeters, because the remaining 8 millimeters will be compensated by the soft tissue and the surgical guide, the length of the surgical guide. So that is the reason this is called as an extended surgical guide kit. And then you can see this is color coded also. Depending upon the width and the length, all the drills are color coded, so that it becomes easy for you to place the drills into the osteotomy site. Now this is the surgical guide. When you are going to place it in the jaws, you have to anchor it to the jaws. So the anchoring pins into the anchoring holes, you have to do a pilot osteotomy and place your anchoring pins into this osteotomy. That's why you are going to stabilize the surgical guide. Once after you stabilize the surgical guide, you have to place this drill guide. The kit is going to have something called as a drill guide. And then after placing the drill guide, you have to place your surgical drill into this drill guide and do the osteotomy. So this drill guide, the width of the drill guide will be same as that of the width of the surgical drill. So when you are using a 2 millimeter drill guide, you have to use a 2 millimeters surgical drill. If you are using a 3 millimeter drill guide, you have to use a 3 millimeter surgical drill. So this is going to be like this. This is a drill guide. This is the sleeve of the surgical guide. And then you are using the surgical drill into this directly into the osteotomy. That's why I told you, when you are using a 10 millimeters, if you are placing a 10 millimeters implant, you have to use a extended drill. These are all the specifications are given in the prescription sent by the lab people. So this is how the surgical guide is going to be fixed onto the jaw with the anchoring pins. And once after this is fixed, the first thing what you have to do is use a tissue punch and then remove the tissue punch. Will be available in the kit, surgical guide kit. So remove the tissue in all the osteotomy sites and then start doing the osteotomy. As I told you, you have to use the drill guide and the drill also, whatever the width, which is specifically it is given in the prescription. So either you can do all the osteotomies at a time, or otherwise you can complete one osteotomy in one hole and another osteotomy in the second hole, like that. So according to the specifications given by the lab people, you have to complete the osteotomy, a series of width increasing in all these osteotomy sites, and then complete your drilling protocol. So once after you completed your drilling protocol, either you can place your implant directly through the surgical guide, or otherwise you can take out your surgical guide and then place implant freehand. Because anyway you have completed your osteotomy flapless, the implant is going to go directly into this. The only advantage with this is you can visualize where exactly your implant crest is going to be, whether it is going to be supracrestal or subcrestal. Immediately after completing this, take a check X-ray and then see whether your placement is appropriate or not. So take a check X-ray and see all the implants are properly. Usually so much of parallelism, usually you'll get only with the surgical guides. Only an experienced hands will get. Without surgical guide, you can place implants like this. So after that, you take a CBCT just to see with the position of your placement of the implant and whether your surgery is accurate or not. And then immediately whatever the interim process the patient is wearing, you reline it and then give it back to the patient. Then wait for the healing period, an uneventful healing of 4 to 5 months. You call back the patient and then go ahead with the second stage surgery, where you punch open the tissue and then place your healing abutments. And then you take impressions and fabricate a custom trace. After fabricating the custom trace, you take out the healing abutments and put the open tray impression copings. This is all covered by Dr. Vasudha. What exactly she told, the steps are going to be in the same manner. After placing the impression copings, take a check X-ray. See that all the impression copings, open tray impression copings, are passively fixing onto the hex of the implants or not. Any discrepancy in this position, any active fitting of your impression copings, all the impression procedures will go wrong. So always try to take a check X-ray and see whether your impression copings are going properly or not. Then coming back to the prosthetic phase, you have to make holes into your custom trace, and you see that it is passively going on to all the impression copings. and then take a rubber base impression. You pick up all your impression copings into the rubber base and then attach your implant analogs to these impression copings and then send it to the lab. The next day, you are going to get a jig trial from the lab. So check this jig trial to the both upper and lower arch and then take a check X-ray. Again, everything has to be passively fitting onto the implants. Any discrepancy in this, again, what you have to do is, if suppose one screw is not fitting properly, cut the jig trials here and then you put some pattern resin, you fix this screw properly and then put pattern resin and then fix it properly and then take one more impression and send it to the lab. So once after your jig trials is ready in the lab people are going to send you bite trims, and now this is on just like your complete denture. With the bite trims, take the jaw relations and send it to the lab. Lab people are going to send you back the wax strain. Check the wax strain and send it to the lab again. Now at this stage, the lab people are going to do a CAD/CAM design of both the maxilla and mandibular framework. This framework, as I told you, it can be done either with the nickel chromium or cobalt chromium, but in this case, we planned for a titanium framework. So this CAD design, after this completing, they will send it to you again to check clinically and then radiologically whether this framework is fitting properly or not. So once after this is passed through, send it back to the lab people. They are going to lay the composite, as I told you, Visualign from the Bread Group. Visualign is a composite where it has pink and white composite layering. Layering can be done directly onto that, and then they will deliver the processes to you. The process will be fixed onto the patient, take a check X-ray, and then finally the hybrid process is delivered to the patient. This is how the patient has come to us. This is how we delivered the processes. So in conclusion, basically these are the newer materials, composite layering. The most advantage with this is the titanium framework, which is low weight, and the composite layering, which gives more aesthetics, and it is easily repairable. One is whenever there is any fractures of the crowns, it can be easily repairable intraorally, and then whatever the access holes are present, it can be closed with white and pink composites. So that's how there is a lot of advantage with this. But only thing is, this is a delayed protocol case where we had taken our own time because the patient is periodontally compromised and a lot of bone loss is present. So we have done everything in a stage-wise manner. And as the patient is a very young patient, 46 years old, and she doesn't want any problem within the next 20-25 years, we have gone for the best of the best implants, surgical placement, surgical guide placement of the implants, and the final process is also one of the best processes available during that time. Coming to the next case, this is a case where we have done a immediate loading protocol. This patient, she is about 65 years old, Swarna Kumari, who came to us with a chief complaint of missing teeth in the upper arch, missing teeth in the lower left arch, 4647, and the root stems, presence of root stems in 43 and 44. Basically, she wanted to get a fixed rehabilitation done. She is already using last 1 year, she is using a complete denture, and then now she wanted to go for a fixed process. So basically, all the routine investigations we had done, we had taken a CBCT just to evaluate the bone in both the upper and the lower arches where we had to place the implants. So what we had done is, in 3637 region and 4344 region, we have placed the implants directly, and then we have put the stock abutment and we have temporized the implants immediately. Coming to the upper arch, the second day we had done implants in the upper arch where we had done an all-on-4 concept in the anterior region. And then I had put the multi-unit abutments immediately into this. And then posteriorly, bilaterally, I had to do a sinus lift procedure as there is no much bone there. I had to do an indirect sinus lift and place 2 implants on either arch. But I made it submerged. I put the cover screws and then closed it. Whereas in this anterior region, where I had put the multi-unit abutments, I had put a temporary titanium cylinders. And then whatever the denture patient is wearing, I had that picked up the titanium cylinders into the denture And then I modified the denture, our existing denture, I modified it. I removed the cantilever, I removed the palatal plate, everything. And then I modified it immediately and then fixed it back. So it's something like what Dr. Sudhir has said, teeth in an hour. So we modified the same denture and then fixed it back to her. So this is how it was. And after the 2 or 3 months, we started the second stage procedure in the upper arch. I removed the cover screws and placed the healing abutments, waited for about 1.5 months, and then gone ahead with the impressions. Same procedure like open tray impression copings, fabrication of custom tray, open tray impression copings, taking check x-rays, and everything, send it to the lab. From the lab, I got the jig trials. This is jig trials. Again, take a check x-ray and see whether it is fitting passively or not. And then you will get a framework. Again, check the framework, see that whether it is fitting passively or not, and then send it back to the lab. From the lab, you will get an acrylization done. You will get a hybrid process. This is the hybrid process. These are the intraoral pictures. And this is the lower arch where where I had done a screw retained DMLS crowns. And this is the final process is glued onto the upper and the upper arch. So basically you can ask me, the question here is, when you are done all on 4, why you have to go with the sinus lift procedure and putting 2 implants in the posterior arch? You could have directly done a upper all on 4 and then go for a permanent process in the first stage itself. If you see, there is a broad lower jaw, comparatively broad lower jaw is there, and the patient is also heavily built and the biting forces are also more. When she came with the upper complete denture, you could see a lot of attrition of the teeth is present. So what I had done is, that is the reason I had to place 8 implants in the upper arch to compensate for the complete lower arch. And one more thing is, already she is having a PFM bridge in the lower right aspect and then lower left aspect also. And then I am going to give a DMLS crowns in this. So everything has become ceramic. And the patient was having a deep bite also earlier. That is the reason you can see some amount of bone loss in this region. So anyway, the patient is going to have a heavier forces. I had to restore it with more number of implants. So that is the reason I had to give, instead of only on 4, I had to give 8 implants and go for a permanent process. These are my case presentations. Anything else? Dr. Ram?
Thank you so much, sir, for the case presentations. They're very planned, well executed, and also well documented. Sir, I have a question from one of the attendees. I want you to answer that. It was regarding all on 4 versus all on 6, and from an economic point of view for the patients.
See, basically it depends upon the amount of the bone available in the anterior region. If a good amount of bone is available, it's always better to go for all on 6. And especially in the maxillary arch, it's always better to go for all on 6. If suppose you had done an all on 4 because of unavailability of the bone, and then if at all a single implant fails, again you have to go for a new process. So it all depends upon amount of availability of the bone and then opposing arch also. See, always lower you can always go with a all on 4 and then manage it for a long term. But upper arch, I always prefer to go for more number of implants when compared to the lower arch.
Sir, one more question is regarding multi-units and regular units. Can we use a combination of both?
Usually I don't prefer that. When you are using multi-units, whether it is a straight implant or a tilted implant, always use all the multi-units. Using only multi-units on the tilted implants and the straight stock abutments on vertical implants, I don't prefer. If you are use multi-units for all that. Because it is something like a stress breaking. When you are using a multi-units, better to put multi-units on all.
Yes.
Any more questions?
Yes, sir. Thank you so much for that, sir. Now, I'd request Mahendranath Reddy, sir, to present some of his cases.
Okay, it's rather good evening or good evening, everyone. I think everybody's seen a lot of cases around. I actually want to stress upon 3 or 4 points through my cases, and there are multiple cases that I'm going to do, and I'm not going to do a case presentation as such, but a salient features, which are, I think, as a prosthodontist, you should check. First point would be the planning of your implant surgery. And as Sudhir said, backward planning or end in mind. Have your processes in place. I would normally put it in this way. When you can change the place of implants where you want to, but you can't change the place of teeth that is going to given to the patient, because that is the place which is fixed and that's the place the patient wants his tooth in. The second point I want to stress and little more elaborate is prosthetic space. The third one is how do we modify, place the implants so that all my screws comes in a favorable position as either lingually or at the cingulum region. The last one is I'm just going to talk about a little more advanced material and more advanced two-in-one kind of a technique in prosthetic making. With this brief introduction, let me go through it. This is my planning, actually. When I've actually taken this case because if you can see the maxillary bone, it is little too big. Huge fellow, good bone. Even the complete denture, if you can see the denture, the teeth are lingually placed. Originally, he had a bimax proclination, but he did not like that space, the aesthetics. And the denture, when somebody is made or we made the denture, the teeth has to be put lingually, and the labial flange is completely taken out, just to maintain the lip profile as a lip support. In this kind of a case, I will be using this case to explain all my 3 salient features, right? First thing is I planned this case properly with the help of CBCT and the planning softwares. This is Noble DTX Studio software, and saw that all my implants are in position. And I also has assessed whether I have to trim the bone or can I do in the same position. Because when I thought of doing implant bone preservation, the problem was all my access holes were coming in the labial side or buccal side. It's always better to get them into lingual side. That's one. The second one is the prosthetic space is much reduced. Depending on the prosthetic space, you need to plan your materials too. It is not that you plan your material and then call for prosthetic space. The basics that you cannot change are the one factors that you have to consider in countervening or negotiating your successful processes. That's one tip that I would like to give everyone of that. Let me talk about prosthetic space. Everybody knows in final year denture making that you know that we need an interridge space of minimum of 17 millimeters for upper and lower denture. Why do you do that? Let me take you back into final year BDS. You need the denture base, which is minimum of 2 millimeters. You need teeth height, which is somewhere around 8 to 9 millimeters, and both come to 16 millimeters on upper and lower, and 2 is 20 millimeters, and a fever space of 2 millimeters that contributes to the denture space or a prosthetic space. It's very easy to get that kind of a space in complete denture. The moment we go on to the prosthetics, that's completely different. Okay, I'm not able to see the prosthesis. Let me see, I will do that. Okay, I will take it off. I'll put it on the full screen. What's happening? Just give me a second. I'll just be back. I'll just take this off.
No problems.
Yeah. This is what in a cross section you see a prosthetic space. The prosthetic space again depends on kind of prosthesis that you give, the material that you're going to use. Thinner the prosthetic space and thinner the material, you need to have a stronger material so that it can be rigid and durable even in the smaller thicknesses. Let me talk about prosthetic space. Prosthetic space in a complete denture is from here, right from the tissue level to the highest part of the denture. That's known as prosthetic space for the upper. Similarly, and the whole thing with this previous piece is called how much is the space available for your denture. The moment we go into implant as such, you have many more components. If you can see, if I do the same thing here, my denture space or the material that I'm going to use is going to be so thin that it's going to break off. Now the space, if you can calculate, that is my implant level. Then I need space for my multi-unit abutment. I need space for the actual abutment, and I need space for the material that I'm going to replace. If you can see little more carefully, vertically it is fine. The moment I see the palatal side, it becomes so thin that it's going to break off. This prosthetic space in implantology, the moment you come into implantology, is not only the ridge to ridge space, it is also a prosthetic encroachment of the tongue space and the palatine space. You have to consider all these before you come out with a conclusion that I am going to go this kind of a prosthesis. Hope I'm being a little more clear about these. Let me talk about this. In a complete denture, this is my prosthetic space that I require because I have a palatine contour which is already resolved. I will be able to do that. But in prosthetics, I need more space or stronger materials to create that kind of a space, right? I'll go ahead with this, I think. The next one is I've carefully planned. If you can see this, you can see on the left-hand side on the denture, there'll be a vertical line moving. Each implant is being planned so that my axis holes are exactly going to be on the palatal or on the lingual side. This is a second implant near the premolar. This is the lateral insert premolar. Even here, if you can see, it is on the cingulum side. Third, the other side of it. Fourth, on the premolar again. Fifth, on the molar. I have equally distributed the implants so that my pillars, my implants are equidistant. Is it really necessary? As far as possible, like an engineer's principles, you have to have all those foundations equidistant. In some cases, when you cannot do it, you can have a compromise. Like if your one or two can be a little closer, but keep it in mind, there are certain parameters that you cannot have two implants. Space between two implants have to be minimum of 3 millimeters. If you compromise on that, you are actually compromising on the longevity of those implants. Try and have minimum of 3 millimeter space between two implants. This is one more takeaway that I want to give it to you. The third one is having an access hole. In this case, just let's see if I place an implant at the crest of the level, if you can see where my prosthesis screw is going to come out. There are two ways of doing it, having an angulated abutment or angulated screw channel and getting it. In this case, I've already used a 30-degree angulated multi-unit abutment, which is even then coming out labially. It is impossible for me to put any more thing on that. That's the maximum angulation of a multi-unit abutment which is possible, and scientifically proven that you cannot have more than 30-degree multi-unit abutment. If you do that, that means your forces which are going to be transmitted will never be in the center of the implant, even if you do all on four. Scientifically, it is not necessary to have, or it's prohibited to have more than 30-degree of multi-unit abutment, or maximum 35. The 35-degree multi-unit abutment will be able to compensate 70 degrees. That's a different topic altogether. That's a different story altogether. But please don't believe in having 60-degree multi-units, which will be very determined, very bad for the implant, because it will never transmit the forces all along the long axis of the implants. In this, what I did to get this implant screw into lingual is I buried the implant little more deep. Just observe, just taking it inside. Now, can you see, just by pushing the implant inside and cutting off that crustal bone, doing an osteotomy there, my lingual, the access screw is completely shifted lingually. I will go back, see this, by doing this. Hence, in planning, now I know that I need to cut off the crustal bone, place this implant much deep inside. This is bone excess. And then get my prosthetic tooth in place exactly there. And even then, my lingual screw has to be palatally placed so that aesthetic problems does not arise. Now, this bone reduction is done not for prosthetic space as such. It also is being done to get my aesthetics in place. Hope I'm able to make you understand this. Let me put another thing which is called a 2-in-1 technique. This was the case that is being presented. In this case, I thought I would do an implantation, planned everything. I've used a pilot drill guides because that's much easier. We can even do a fully surgical guide, fully guided surgeries. I've placed my implants in position. After impressions, this is what I did. I've created a peak injector molding lower base, peak upper base. Both of them on the articulator looks like that. I have enough space. And at the same time, I also milled HIPC, which is called a composite, which is high performance composites. I made upper and lower crowns all together. This is planned nicely. This is the base of it. That is the suprastructure, which is layering material, right? Then I put them onto it and glued it together. Similarly, it becomes like that. And veneered it with composites, which are creolines, braided materials. And this goes into the mouth with little bit of customization. The HIPC is a monolithic material. I can even paint it, tint it, or cut back and do this white aesthetics and pink aesthetics on it. And then final result would be something like this. I think with this small presentation, I've given you 3 or 4 salient features and the latest materials that you can do. This material, the advantage is it is very, very resilient. It is the peak is almost, the modulus of elasticity is almost like bone, and HIPC is kind of composite, which wears out and gives you a shock absorption. Hence, your implants will be very, very healthy. And the wear resistance is claimed by the manufacturers for 7 years. I think 7 years is too long. Even 5 years, if the process lasts, we will be able to change the processes. Patient don't mind it. And that will give you a much better long-lasting implants, the simple maintenance. And I think they will be, the implants will serve as expected to 70 to 80 years. Thank you. If there are any questions, please, you're welcome.
Thank you, sir. Thank you so much for that presentation. And you have beautifully explained the prosthetic space. And the last case, sir, regarding the recent materials, I'm not sure how many actually understood that.
Okay.
Sudhir, sir, can you just if you can, like, speak about the newer materials, sir?
Ram, I would like to bring this
Your comments
observation.
on the last material
Yeah,
that
yeah.
Sir showed.
The polymeric materials, right?
Yes, sir.
Yeah. Sir had a very good thing to say, because I see most of the practitioners today having to understand that, zirconia is the ultimate go-to material when it comes to, cost recovery for the practitioner, and also in terms of the aesthetics, right? And there is the PFM, that is the porcelain fused to metal, and now we have the higher polymers which are used for the superstructure and processes. What Sir mentioned there is a shock absorption. The flexure of the process is a twin-edged sword, but the shock absorption is something that we have to always look into. Zirconia, for example, if you even take a regular restoration, I believe a layered veneered superstructure, like say ceramic over metal or ceramic over zirconia, acts like a fuse box. So also the recent polymers. Why I call it a fuse box is that it's always not very easy to understand how articulation works in a particular patient, and you could always end up with some interferences that are there in the beginning, or that might come to being after some time, right? So when you have layered materials over the superstructure, these layered materials will indicate any occlusal trauma uh, to the process by itself. And for example, if it is a layered ceramic, the ceramic chips off, right? And if it is composite, it'll wear off. And all this happens in a way to save the implant and from any biomechanical loading. It's something like the fuse box. When there's a surge in the voltage, the fuse breaks, and the circuit is saved. So the idea that using zirconia is as a go-to material for aesthetics is misplaced. One, and we should always look into materials which help to flex and thereby absorb the shock of occlusal loading and biomechanics. uh, Coming to the newer materials, you have the high performance polymers, like sir has mentioned. Now these are all from a family called as poly ether ketones, right? And the polyether ketones have been introduced into the industry, a lot of automobile industry and the space industries, and they've been borrowed from there for dentistry. And by changing a few functional molecules, we have devised different type of PEK polymers, out of which we have the polyether ether ketone, or PEEK. We have polyaryl ether ketones, and the later, I mean, the more recent ones are polyether ketone polymers, which have been infiltrated with zirconia or ceramic fillers, like the high performance polymers. Now these have the advantage of providing for the wear resistance, and that's why my Mahendra Reddy sir has mentioned that the manufacturers give you an assurance that they can tolerate wear resistance of 7 years. Now with just PEEK, that might not be possible, but with infiltrated PEEK like BioHPP, that is very much possible. Now, with regards to the latest material that I know, there is something called strinia, which is again ceramic infiltrated, and there is the graphene. Now, graphene has been understood worldwide, not just in dentistry, to be something like a miracle structure. Graphene is nothing but your lead graphite, your pencil lead. Lead has multiple layers of carbon. Graphene is a single layer of carbon. Graphite is cleaved. You have a single layer of carbon which is arranged in a honeycomb type of a lattice. And this material is so strong that they claim that it can stop a bullet. It is used in the bulletproof armors. And that has been applied to dentistry. And now we have graphene superstructures which bond tremendously well to composites and other polymers. So amongst the latest materials which hold promise, I think graphene is one that you should look forward to. I hope I've addressed the question, Ram.
Yes, sir. Yes, sir. You have.
I think I'll put them a little more structure on the screen. I'll share my screen and give 2 slides,
Sure, sir.
which tells about the modulus of elasticity and the resiliency.
Perfect, sir. Perfect.
I think
Thank
they
you.
will understand much better.
Sure, sir.
Mahi, you have exactly 2
that.
minutes to do that.
It's too much. 1 minute is good.
Then let us stop at this. May I invite our...
I can do it in 1 minute.
Yeah. May I invite our former teachers, Dr. Ramchandra Reddy sir, Dr. Jayakumar sir, Dr. N.S. Sadhav sir, Dr. Ravindranath sir, retired Major General, Lieutenant General, and also Dr. Bapaniya sir to unmute their mics and
Vivek,
also
can
switch on
I
the
finish
videos.
this presentation for 2 slides?
No, Mahi, we have no time now. So we have to just invite Dr. Ramchandra Reddy sir to speak few words,
right.
please.
Hello.
Yes,
Hello?
sir, please. Yes, sir, please switch on your video,
Can
sir.
you hear me?
Yeah, we can hear you, sir.
What about video?
Yeah, you have to switch on your video, sir.
Okay.
Yes, we
Is
can
it
see you.
okay?
Yes, sir, we can see you.
Can you see me?
Yes, sir, you are as usual like a James Bond.
Yeah.
Sir, good evening,
Thank
sir.
you.
Good evening, sir.
Good evening to everyone. I'm really enlightened to hear this webinar on implantology. It was wonderful for experience for me because I'm totally new to this. I congratulate the speakers. They spoke very well. They spoke so much of advanced technology and
Sir, you have to unmute yourself, sir. I think you have muted yourself. Please unmute yourself.
Sir, unmute చేయండి సార్. మళ్ళా accidentally గా mute చేశారు మిమ్మల్ని.
Your mic switch on చేయండి, sir.
Okay. Meanwhile.
Yes, sir. You got it.
Sir, please unmute yourself. Your mic is muted. Sir, we'll come back to you. May I invite Jay Kumar, sir?
Can you hear me?
Yeah,
Yes,
yeah,
sir.
we can hear you, sir. Please go ahead.
We can hear now.
No.
I request all other people to mute themselves to avoid any crosstalk. Thank you. May I invite Lieutenant General Ravindranath sir, who is joined us from Chicago, to speak a few words.
Welcome, sir.
Good evening to all of you.
Good
At
evening.
the outset, I would like to thank Dr. Vivek Reddy for having invited me for the webinar. And I am very happy to know that my teachers, Dr. Ramchandra Reddy and Jay Kumar, are also present. That is really very heartening. And also many friends with whom I associated. And one thing is implantology, I would say it is a very fascinating science that dentistry has today. Ever since we started, we in fact started making indigenously, but ever since, a lot of changes have come, a lot of improvements, a lot of technology has come in for the benefit of patients' comfort and also better aesthetics and better functional aspect. And in fact, it is very interesting to note many of the specialists and also some of the generals are practicing implantology in a big way. And I wish the webinar a success, and at the same time, let the science reach its pinnacle of heights with the experts whom we have in our own place, that is in Hyderabad. I'm sure we'll have more and more webinars. Only thing is, unfortunately, I was not there physically, but it was really an excellent beginning that is made by the alumni, and I'm sure it will flourish in the days to come. Thank you.
Thank you, sir. Thank you, sir. Thank you for
to all of
joining
you.
us from Chicago. May I invite our teacher, Dr. Yadav sir, to speak few words, please.
Hello, good evening to everybody.
Good evening, sir.
Yeah, I'm happy that webinar has gone well, even though it may not be helpful to people like me who are retired and non-clinical, but it will be very good for present teachers, practitioners, and PGs. All the best, Vivekanand Reddy and GC, and thank you for the panelists.
Thank you, sir. May I invite Jai Kumar sir to say a few words?
Vivek,
Yes, sir. Please go ahead.
Can you see me?
No, you have to switch on your video, sir.
Video has to be on. We can only hear you.
Where is the
But
video?
please go ahead and keep talking, sir.
Anyhow, because you suddenly caught me with pants down, because I was not prepared for a facial this thing. I went inside and crossed
No
my
problem,
hair
sir.
and
All of
applied
us
a
are like
little.
that only, except our president, sir, who is wearing suit, boot and tie. All of us are in the same boat.
I applied a little powder on my face.
Okay, no problem.
No problem, but still, comparisons are very deceptive. No, I am still young. So I am very glad to be listening to you, and I am privileged to have been associated with Sudhir, Vasudha, and Vijay Srinivas. Vijay Srinivas is an oral pathologist. Kada?
On sir.
Oral pathology, but branching off into the intricacies of implant dentistry. That reminds me of that Bombay oral pathology person. No, he is a smile guru or cosmetic top class practitioner. Vijay is in a different league, but what I could hear, he was so lucid in his expression, and Vasudha also was very nice.
Thank you, sir.
And
Thank you, sir.
I remember her from the day one when she was in a first year student. And I don't pretend that I understand all the Carnatic music, because I am a traditional person, and actually implantologists are my enemies, because extract implant, we are prolong and preserve. That is our attitude. And sometimes the implantologists have hijacked periodontology also. There was an editorial in one journal, but that is on the less, lighter vein. Unless you swim with the tide, you are left behind as a bystanders. And I thank the president of the alumni. He's all in smiles and tie and this thing. And most of the people whom I had occasion to see, they have lost hair on this thing, but surprisingly, I am retained most of it.
You forgot to mention Mahi, sir.
Mahi Debonier. He needs a special mention. He is the guru of implantologists in Andhra Pradesh. And yes, because suddenly I was asked to be speaking to people. So in that rush of adrenaline, I forgot about Mahi. Sorry, Emankodu. We always take friends for granted, right? Thank you so much, Vivek, Mahi, Vijay, Vasudha, and Ram Base. He is the person who has been coordinating it so well. And I wish the next round of webinars will go with not so much of request for the organizers to join in. There will be spontaneous interest to join. And thank you very much.
Thank you, sir. May I invite Dr. Penugonda, Bapane Penugonda, sir, who has joined us from University of New York, to our alumnus, proud alumnus, who is working in US, to say a few words, please.
Thanks, Vivek. Great presentation and great organization. I'm really glad I'm part of it. And I really enjoyed my days back in
your video on, sir.
If you can
I'm sorry?
your video, sir, we'll be happy to see
Your video on.
Video. I'm really surprised I cannot see video on.
Next to the mute button. Next to the mute button.
Next to the mute button, I don't see it. That's the problem. Okay, let me see if I can cancel.
No problem, sir. Please go ahead.
Okay, so I just wanted to let you guys know that, when I joined NYU in 1980, my first publication in 1982 or 83 is Ailing and Failing Implants. That was my first publication. At that time, when I spoke to all the people who were doing implants, they used to come to me because I was in the biomaterials department, and they wanted to know why these implants are failing and what was the issue. And they said they couldn't sleep. When they put the implant, they couldn't sleep. So now, today, I see this wonderful work, and people are so happy, and the practitioners are so happy placing these implants and restoring these implants, and this is amazing. And now I see at NYU, my undergrad students, they're doing implants, and it's their requirement. They have to do one implant, at least restoration. And it's a great advancement, and I'm really, excellent, progress in the implant. That's the only area I think we are progressing in a dental area, and I think we are doing very well. And thanks for inviting me, and it's a pleasure and honor to be here. And I'm glad to see all my teachers, and thanks Chandrasekhar, and for all the hospitality you gave me every time I came to Hyderabad. Thank you.
You're most welcome, sir.
Thank you. Thank you very much.
Thank you, sir. Sri Krishna, please go ahead and propose a note of thanks.
Yeah, before Vivek, 1 second, give me just 10 seconds.
President is president.
Before Sri Krishna gives the vote of thanks, I want to mention that Sudhir, I've known your father so well, and you are so humble and silent, but now you are a very good speaker, and you have so much talent.
Thank you, sir. Thank you. Thank you so much, sir.
And and Vivek is the only person who is responsible for this whole program. If not for Vivek, this webinar wouldn't have been like this today. And I think the 100% or 200% marks for this program has to go to Vivek only. And thanks to all the teachers who are present, and all my seniors, juniors, and colleagues. And finally, in dentistry today, implant is the money. Money only gets from the implants, nothing else. No orthodontia, no surgery, nothing, only the implants. So I think everyone has learned a little bit. Sri Krishna, all yours.
Thank you, sir. Sri Krishna, please go ahead. Sir, there is money in oral surgery and ortho also. Don't be disappointed.
No, it's not disappointment. It's only fast.
Can everybody see my screen, sir?
Yes, yes, we can see you.
I guess the vote of thanks is already done, sir. But then all the seniors, there is.
Go ahead.
Dr. Sri Krishna, you're on mute. Please unmute yourself.
Please unmute.
Yeah, you can hear me, sir?
Yeah, now we can.
Yeah, now it's okay.
So, as I was saying, the vote of thanks is already done, but then it is my duty. So, good evening, everyone. It is indeed a privilege to propose the vote of thanks for the first webinar of the Alumni Association of Government Dental College, Hyderabad, which, as you can see, has turned out to be an outstanding event with 500 plus registrations. At the outset, I would like to thank the President, Dr. G. Chandrasekhar, Dr. Narasimhaswamy, the Treasurer, the Secretary, and the Treasurer, Dr. D. Ramaraju, and all the Executive Committee members of the Alumni Association for their continuous support and valuable inputs in making this event a grand success. I would also like to thank the Principal and faculty members of Government Dental College, Hyderabad, for their sustained backing and patronage.
Please show your screen, Sri Krishna.
So we can see the screen.
Okay. Please go ahead. Please go ahead. Again, you are muted.
Yeah. Okay. So it is. It is indeed a blessing that we have amongst us several senior alumni members like Dr. P. Ramchandra Reddy, former principal and professor of Department of Oral Medicine and Radiology, Dr. A. Jayakumar, former professor of periodontology, Dr. N.S. Yadav, former faculty at Department of Oral Medicine and Radiology, Lieutenant General Dr. T. Ravindranath from the 1961 batch, Dr. Bapnaya Penuganda, and Dr. G.N. Rao. This being an online event, and my inability to see all the attendees on my computer screen at once, please pardon me if I have missed acknowledging other senior members, but I would like to express my heartfelt gratitude towards all of them individually for taking time out to attend this event in spite of their busy schedules. Now, a big thank you to all the resource persons, namely our speaker for today, Dr. N. Sudhir, who was passionate from day one and raring to go for sharing his knowledge. And our distinguished panelists, Dr. K. Mahendranath Reddy, Dr. G. Vijay Srinivas, and Dr. N. Vasudha, who all are the names taken with in the field of implantology. I would also like to thank Dr. Ram Basani, who has played a brilliant role as a moderator with his exceptional coordination skills. And I would also like to thank Dr. Sandeep Nalla for answering the attendees' questions in the chat box. Now, no event would be a success without the active participation of the attendees. I would like to thank all the attendees for their enthusiasm. Your numbers show the trust imposed on the Alumni Association of GDC Hyderabad in the organization and conduction of enlightening scientific events. I would also like to thank the scientific committee headed by Dr. N. Vivekvardhan Reddy and its members in planning and organizing an excellent and enriching webinar. Last, as I say, but not the least, I would like to acknowledge the back-end support provided by Mr. Gaganjit Singh and his team at WOW Alumni Networks, who very diligently helped us conduct this event in a smooth and nice manner. We at Alumni Association of GDCH Hyderabad look forward to meet you all again in the upcoming webinar on a very interesting topic, tracking the cracked tooth syndrome, on the 24th of this month, which is a Sunday, from 6 to 7:30 p.m. The speaker would be Dr. Shashidhar Nalapati from the 1988 batch. Once again, thank you everyone. We'll sign off for now. Have a good evening.